Yes, ma'am. We are
Radhika
ready.
ma'am, please.
Yes, ma'am. Shall I start?
Yes, yes.
A very good evening to all our esteemed guests, speakers, and delegates. On behalf of TNFOG Marathon CME in Heart Disease in Pregnancy, organized by Dr. Revati Janakiram ma'am, Dr. Sampath Kumari ma'am, and Dr. Vijayalakshmi Yanasekaran ma'am. By the grace of God, every program started will be a big success. Hence, I invite you all for the lamp lighting ceremony. May I invite Professor Dr. Revati Janaki ma'am to invite our chief guest and guest of honor. I will introduce ma'am, who is a former.
Just a word is enough.
Okay, ma'am. Madam is our Vice President, Foxy South Zone in 2016, and she is the current president, TNFOG 2023. She's been the former director of IOG Chennai, and she's received Dr. Durusha Community Services Award, Lifetime Achievement Award, IMA in Madurai, and she's been selected as Master Trainer for PPAU CD program, and she's the author of Foxy Focus on Amniotic Fluid A to Z, contributed many chapters in Foxy Focus, PG and UG books, and she's received the Pride of Foxy Award in November 2019 at Mumbai.
Thank you. Thank you, Radhika, for your
Thank
kind
you, ma'am.
introduction. It's my great pleasure to welcome you all to this TNFOG Marathon CME on Heart Disease in Pregnancy. And it's my pride and privilege to welcome our chief guest, President-elect Foxy, Dr. Jaydeep Tank, who will be joining soon, and our beloved Dr. Anjala Chandrasekhar Madam, past President TNFOG. And also, with great pleasure, I welcome our regular judges, Dr. Niti Sharma and Vijayalakshmi Kanthasamy, and Yuva speakers, Dr. Divya and Bhumika. And quite interestingly, this time we are going to have talk from Dr. Justin Paul regarding this cardiac registry, which is very, very important. Everyone should know about it. And Dr. Chitra is there to lead the panel discussion on clinical cases, management of heart disease in pregnancy. And I'm sure this is going to benefit all the practitioners. And once again, I welcome you all to this Marathon CME. Thank you very much.
Thank you, ma'am. Could you please introduce the guest of honor, Anjalakshmi ma'am?
Dr. Jaydeep Tank not yet joined. Okay. Oh, guest of honor. Okay, I'll introduce. It's my great pleasure to introduce Madam Dr. Anjala Chandrasekhar, who was the immediate past president and founder president of TNFOG, and she's senior consultant at Chennai. She was also past president of Oxy. She's a governing council member of DIPSI, and all of us know the hard work
Hello,
put in by
ma'am.
her in GDM. And she's the recipient of Best of Doctor Award in IME, retired professor and, from Madurai Medical College, Madras Medical College, and retired professor in OG Mada Medical College. And she has presented many papers in national as well as international conferences. And all of us know her whenever we think or talk about GDM. So our beloved founder president TNFOG, I welcome you, ma'am, to say a few words and bless this meeting.
Thank you, Dr. Revati, for this nice introduction. Good evening, everyone. Beloved Chief Guest, the President-elect, Dr. Jaideep Tang, the TNFOG President, Dr. Revati, Secretary, Dr. Sambat Kumari, Treasurer, Dr. Vijay Lakshmi, and other office bearers of TNFOG, the chairpersons and the moderators, speakers, panelists, and judges, and my dear delegates. It is a very proud privilege and honor to be the guest of honor along with Dr. Jaideep Tang, the chief guest for this Marathon CME. I am very happy to see the growth of TNFOG by the untiring efforts of Dr. Sambat Kumari, and the Marathon CME is also a brainchild of Dr. Sambat Kumari. I thank Dr. Revati and Dr. Sambat Kumari for this wonderful opportunity. And today's CME is a very important topic, heart disease complicating pregnancy, which contributes considerably to the maternal mortality, morbidity, and the prevalence is around 1 to 4%. The advances in the technology, diagnostic procedures, and advances in anesthesia and interventional cardiology has helped many women to live during the reproductive years and to go through the pregnancy. Many heart diseases during pregnancy are under investigation and may not be understood, and some require a further inquiry. Some of the diseases may be the exacerbation of pre-existing conditions that the pregnant women may already have, or that may be they may develop a new disease process that presents because of the complex hormonal changes and physiological changes of pregnancy. Though there is a significant risk involved in such pregnancies, one can successfully treat the majority of them of this heart disease if detected early, and careful follow-up are part of the routine care. During the first antenatal visit, so my appeal is to have a thorough and careful examination, which is a must. You should not miss the disease. We always say the first examination is the best examination. And the common cardiovascular disease of pregnancy are cardiomyopathy, coronary artery disease, myocardial infarction, and valvular disease. Understanding the pathophysiology in the heart disease with pregnancy is important, like understanding the cardiac output changes, heart rate changes, vascular resistance, and the blood pressure. To talk to us about this, we have an expert, Dr. Justin Paul, who has dedicated himself and started a heart disease registry, first of its kind, I think, in India. And for us, this helps to understand the prevalence of the various heart disease and what is their course during pregnancy, how best we can treat those conditions and improve the maternal morbidity and mortality and the perinatal outcome. We are actually blessed to have Dr. Justin Paul, who is going to talk to us on his experience in cardiac registry. I wish my best wishes for the success of this program. I request all the delegates to get the maximum benefit out of this program, and it is a forum for you people to clarify all your doubts. So I once again thank the TNFOG for this wonderful opportunity. Thank you and Jai Hind.
Thank you, ma'am. Thank you for your blessings and wishes. And we will do a examination, detailed examination on the patients, and we'll follow your advice. Madam, I invite you to release the e-newsletter.
Release this e-sound. Okay.
Yes, ma'am.
Very nice newsletter.
Yes, ma'am. Thank you so much, ma'am. Now we are moving on to the session 1, Yuva session. I invite chairpersons Dr. Nidhi Sharma and Dr. Vijayalakshmi ma'am. Dr. Nidhi Sharma ma'am is a professor of Obs and Gynae at Savita University. She has done her undergraduation, post-graduation from Banaras Hindu University at Varanasi, India. She's a fellow of Indian College of Obs and Gynae and fellow of Assisted Reproductive Techniques, diploma in IVF and reproductive medicine from UK SH University and Germany, PhD degree in Obs and Gynae from Savita University. She's academic supervisor of fellowship in reproductive medicine and MS in clinical embryology at Savita Medical College. She has received Dr. Jagadish Mishra Prize for Care of Infertile in ACOG 2017, and she has indexed national and international publications more than 100 and has authored several chapters in textbooks. She has been a member of teaching faculty of MBBS and MS and PhD for 14 years and has edited 2 books published in London: Innovations in Assisted Reproductive Technology, Prediction of Fetal-Maternal Syndrome of Preeclampsia. I invite Dr. Vijayalakshmi Madam, who is a professor of Chettinad Hospital and Research Institute, Kelambakam, Chennai, and special prize. She's received special prizes and achievements as a State Secretary Appreciation Award for exemplary performance in IMA activities. An important post held in OXY was past. She's been the past EC member in OXY and president in Velacheri branch of IMA. Has been the chairperson in Women's Doctors Wing IMA Velacheri. Her special interests are high risk obs and gynae, adults and gynecology, and gynae endoscopy. Our presenters in this UR session are Dr. Divya Seduraman, who is an undergraduate, Bachelor of Medicine.
Thank you.
Yes, ma'am.
Shall
Could you
I?
please take over? Yes,
Yeah, sure. Thank you for the introduction. And we now have our first speaker, Dr. Divya Seduraman, who's an undergraduate from PSG Institute of Medical Sciences and has done her PG from Madras Medical College. And she's associate professor at Trichy SRM Medical College and professor at Srinivasan Medical College till date. Madam has won the second runner-up prize in advanced course in medical education and a best poster presentation as well. And the CS Dawn prize for vasectomy, a survey, and best paper award for pulmonary metastasis in cancer cervix at Tech OG conference in Trichy, and committee member in Yuva Action Award in Yuva FOGSI 2013. Over to you, Dr. Divya, to speak to us about the cardiovascular changes in pregnancy.
Just a minute. I'm trying to open my presentation.
Share.
A very good evening. It's an honor to be amongst my teachers, Professor Ranjalakshmi ma'am and Chitra ma'am. My topic, I'm going to be talking to you about cardiovascular changes in pregnancy. What happens during pregnancy is that we have hemodynamic changes. The purpose of these hemodynamic changes is to meet the increased metabolic demands of the fetus and the mother, and to ensure adequate uteroplacental circulation so that the fetus may develop and grow. If there are insufficient hemodynamic changes, we end up with complications like preeclampsia and growth restriction. And if the mother is unable to adapt to these changes, there is usually a silent underlying cardiac pathology which gets exposed during pregnancy. The single most important hemodynamic change or a cardiovascular change that occurs during pregnancy is a systemic vasodilation. This starts as early as the 5th week of gestation, even before the placenta develops. And this is the single most important change to sustain placental perfusion in future. And what causes this is a multitude of hormones, important of which are estrogen, progesterone, relaxin, nitric oxide, and prostaglandins like prostacyclin. There is a suppression to the action of thrombotic prostaglandins or vasoconstrictive prostaglandins like thromboxane A2. Coming to the changes per se, the first important change is an increase in the plasma volume. There's a 40 to 50% increase in the plasma volume during pregnancy. This is mainly because of the activation of the renin-angiotensin aldosterone system, which increases your sodium and water retention, thereby increasing your plasma volume. The hormone relaxin also stimulates vasopressin, which suppresses urine secretion and increases water retention. Paradoxically, progesterone antagonizes the action of aldosterone. The reason being, too much of sodium retention leads to potassium excretion, and we do not want a hypokalemia. So this is the balance that the body does to maintain normal potassium value. So what essentially is, though there is an increased absorption of sodium, essentially, the plasma osmolality reduces, and we have something called a hyponatremic hypervolemia. So the graph to the right shows you the changes that occur in the cardiac output and the peripheral vascular resistance in pregnancy. The cardiac output progressively increases from the first trimester up to delivery. It's maximum during labor and following delivery. The pulmonary vascular resistance, peripheral vascular resistance, in contrary, falls throughout pregnancy. And this is important for the fall in the blood pressure that ensues. So the cardiac output keeps on increasing. So this ensures that there is increased oxygen delivered to the placenta and hence to the baby. The peripheral vascular resistance also increases the blood flow through the systemic circulation. As told before, blood pressure is a multiplier of cardiac output and peripheral vascular resistance, and the blood pressure falls during pregnancy. The maximum fall is during the second trimester. So this is the big pregnancy fall that all of us talk about. The fall is about 5 to 10 millimeters than the original blood pressure, and the fall is more in the diastolic blood pressure as compared to the systolic blood pressure. The mean arterial pressure, however, almost remains normal. Coming to the next parameter, which is the heart rate. This shows a progressive increase by 10 to 20 beats throughout pregnancy, more than the normal, and its maximum in the third trimester. This is about 20 to 25% over the baseline. What happens to the pulmonary resistance? There's an increase in pulmonary blood flow because of the increase in the cardiac output. However, because of the reduction in the peripheral vascular resistance, the pulmonary artery pressure remains unchanged. This is very important because there is a delicate interplay between these two. So any change in the pulmonary vasculature as an increase in pulmonary hypertension is not tolerated by the mother and pushes her into cardiac failure during pregnancy. All these changes come back to normal during puerperium. So what happens to the heart during pregnancy is you have something called a cardiac remodeling. There is a mild left ventricular hypertrophy because there is an increase in wall thickness and mass. However, the myocardial contractility and the ejection fractions remain normal. And because there's also an increase in the vascular distensibility, especially in the aorta, so this ensures that more of blood is pushed into the peripheral circulation. So what is the clinical relevance of all of this? A pregnant mother can have increased fatigue and shortness of breath. Why? Because the maximum increase in cardiac, because the pregnancy is a hyperdynamic condition where there is also already increase in cardiac output, the maximum amount of cardiac output that can be increased in response to exercise is limited. We also have something called the physiological edema in pregnancy. Why? Because of the increased venous pressure due to the gravid uterus compressing on the inferior vena cava, pushes fluid into the third compartment. We also deal with something called a physiological anemia during pregnancy. Why? Because you have an increase in plasma volume and an increase in the RBC count, but the increase is disproportional. We have a 50% increase in plasma volume, but a 25 to 30% increase in the RBC. So this leads to something called a physiological anemia that is seen around 28 to 30 weeks of gestation. The other thing I also want to talk about is the supine hypotension syndrome. So if you look at the graph, what happens? So the changes in the different parameters are shown by the black continuous line. So what happens when a patient lies down is there is the pressure of the gravid uterus on the IVC. There's a decrease in venous return. So this causes a decrease in the cardiac output. Hence, a patient that is lying down in the supine posture can experience nausea, syncope. So essentially, pregnant patients are asked to lie on the left side to relieve this pressure. So what does one find when we examine the cardiovascular system during pregnancy? So what happens is the enlarging uterus pushes up the diaphragm, as a result of which the heart is pushed upwards and a little bit towards the left. So essentially, we have a left axis deviation. So the apex beat is pushed upwards and to the left. And because of the increase in cardiac output, you have a distension, jugular venous distension. You can have prominent pulsations. On auscultation, because of the increased cardiac output, your first heart sound is loud and can be widely split. You can also have a split in the second heart sound and sometimes an occasional S3. Murmurs or physiological murmurs, which are called venous hum, mammary souffle, are heard over the chest wall because of the increase in blood flow due to increased cardiac output. These murmurs can also be heard over the aortic and pulmonary areas. These are essentially ejection systolic murmur, all because of increase in cardiac output during pregnancy. So when we take an ECG, what do you find? You find a left axis deviation. Sometimes you can make out premature atrioventricular beats. However, there is no change in the various intervals like your PR intervals. So all of them remain normal. An echo shows a mild 4-chamber enlargement where the right side is enlarged more than the left side. You can have a mild pericardial effusion, a mild mitral regurgitation, tricuspid regurgitation, and pulmonary regurgitation is normal in an echo. However, an aortic regurgitation is abnormal. Essentially, during pregnancy, what happens is due to increased peripheral vascular resistance, the afterload comes down, as a result of which your regurgitant lesions become better. However, persistent right to left shunts become worse. So what is abnormal in cardiovascular system in pregnancy is progressive dyspnea. If the patient is not able to do her regular work, then she has orthopnea, then there is paroxysmal nocturnal dyspnea, then there is syncope on standing, the presence of diastolic murmurs, all of this should ring an alarm bell regarding potential heart disease during pregnancy. So what happens during labor and delivery? This is when there is maximum cardiac output. So why does this occur? One is because of an increased heart rate. There's an increase in preload because of the increase in catecholamine secretion when the pain is severe during labor. And there is also autotransfusion. By this, we mean that there is blood being pushed from the uterus into the systemic circulation after during contractions and post labor. So this is possibly the most important time where a cardiac patient can decompensate. So this table essentially summarizes all the findings that I have mentioned about. So you have an increase in your cardiac output, you have a fall in the systemic vascular resistance, you have an increase in the heart rate, not more than 10 to 20 beats per minute, your blood pressure falls. Neurohumorally, you have increase in sympathetic activity, and you have various changes brought out by your estrogen, progesterone, and relaxin. The angiotensin-renin system gets activated during pregnancy, and though there is water retention, the body becomes resistant to the vasoconstrictor effect of angiotensin. Hence, the BP falls and does not rise. The plasma volume increases, the RBC also increases, but not to the extent of plasma volume resulting in physiological anemia during pregnancy. There is physiological left ventricular hypertrophy. It's a part of remodeling, which comes back to normal once during puerperium. The chamber sizes of the heart mildly increase, and the aorta becomes increasingly distensible to allow more blood to be pushed into the peripheral circulation. So this brings me to the end of my presentation. These are my references. And thank you for giving me this opportunity to learn and to present. Thank you.
Thank you, Dr. Divya. You were talking about physiological anemia of pregnancy.
Yes.
So what is the criteria for physiological anemia? How do we...
It is a normocytic normochromic anemia, ma'am. The hemoglobin does not, the hemoglobin that drops its maximum is to 10.5 grams. So it being a normocytic normochromic anemia, there is no change, there is not much of change in the blood indices, which is your MCD, your MCH, and the MCHC.
Yeah. So basically, a hemoglobin not less than 10 grams, and also an RBC count which does not fall below 4 million per cubic millimeter. So that's the usual cutoff that the postgraduates also should know about when they're reading the CBC reports.
Yes.
Yeah. And though it is a very often asked question, what is this rule of 5 that we normally talk about when we're talking about a cardiac condition in pregnancy? Is this rule of 5 that we normally talk about, isn't? Are you aware of that?
No, I'm not aware of it, ma'am. I'm not aware of
because you just said that when is the maximal cardiac output which we see in any pregnant
delivery.
woman?
I mean, following delivery.
Yeah, but in the antepartum period, when do you think the cardiac output reaches the maximum?
During 28 to 30 weeks.
Yeah.
During the second trimester.
Yes. So in the 28 to 30 or up to 32 weeks is when the output is the maximum.
Yes.
Thank you. Thank you, Dr. Divya, for your Dr. Nidhi, if you're there online.
Yeah, thank you, ma'am.
Thank you.
Radhika, ma'am. Radhika, ma'am, you are on mute. Please unmute. Ma'am, shall I launch the first question, ma'am?
Yes, yes, please. Sahiti, please launch the first
Yes,
question.
ma'am.
In pregnancy, maternal BP in the second trimester decreases, B increases, C no change, and none of the above.
Ten seconds more. Time up.
Thank you.
Shall we move on to second speaker?
Okay. I request Dr. Nidhi Sharma. Madam, could you please introduce Dr. Bhumika Kunasing?
I think Madam is not there. Otherwise,
Okay.
she will be ready with her questions for each of the speakers. So I will just take it to introduce Dr. Bhumika.
Okay.
She's a graduate from Government Vellore Medical College, and she's completed her MS in OBG from SRMC. And currently she's a registrar at Joseph's Hospital, Chennai. And her special areas of interest are high-risk obstetrics. Welcome, Dr. Bhumika. And she will be talking to us on congenital heart disease. Over to you, Dr. Bhumika.
Thank you, ma'am.
Could you share your slides?
Yes, ma'am. I'm trying to do that. Just 1 second.
Please click on share screen option, ma, which is in green
Yes,
color.
ma'am. Yes. Yes, ma'am. Yes, ma'am. I'm having some issues over here. Just 1 minute. Yeah, 1 second. Ma'am, are you able to see me? Ma'am?
Yes, thank you. Now we are able to see the screen. Thank you.
Yes, yes. So I'm here to talk about congenital heart disease in pregnancy. So as ma'am already told that because of the newer developments in surgical as well as medical field, we have a lot of these children who have these congenital heart diseases who are growing up to the reproductive age group, and they are even conceiving and continuing with pregnancy. So today we'll be dealing with it. And the simple congenital heart disease include mild pulmonary valve stenosis, uncomplicated atrial septal defect, ventricular septal defect or PDA, successfully repaired ASD, VSD and PDA, and successfully repaired pulmonary venous anomalous pulmonary venous connection without important residua. And the complex anatomical and physiological lesions are included under the complex CHD, which includes the tetralogy of Fallot, severe aortic stenosis, and other lesions. So the very main important thing that we have to consider in these women is once they enter into their reproductive age group and reproductive years, they must be risk stratified, and according to which we have to advise them regarding contraception, as well as if they want to proceed with pregnancy, we have to counsel them whether they are fit for pregnancy or not. This is very important, and if they are not fit for pregnancy, we have to counsel them regarding contraception, which is very important. So the risk stratification, we mainly follow the modified WHO classification for the heart disease, and the other classifications which are followed are Karprik and Zahara. So we'll be looking into the modified WHO classification. The class 1 of modified WHO classification has a very good prognosis, and it is almost equal to that of a uncomplicated pregnancy. That is lesions which have been successfully repaired, that is ASD, VSD, PDA, and anomalous pulmonary venous connections which have been successfully repaired, and uncomplicated small or mild pulmonary stenosis, PDA, mitral valve prolapse. And these all come under WHO class 1. So WHO class 1 is as equal to as a normal pregnancy, but still they should be evaluated and monitored. So the WHO class 2 and class 2 to 3 include the following categories, in which you have an unoperated atrial or ventricular septal defect and repaired tetralogy of Fallot and all the arrhythmias. So they come under WHO class 2, and class 2 to 3, they also fall under the gray area. That is, we have to evaluate them completely before counseling them for pregnancy. That is mild left ventricular impairment, hypertrophy of mild left ventricular impairment, hypertrophic cardiomyopathy, any valvular heart disease, and Marfan syndrome without aortic dilatation, or if aortic dilatation is less than 45 mm, and repaired coarctation of aorta. So the class 3 and class 4 are where we must think whether they have to become pregnant or not. And the modified WHO class 4 is a complete contraindication for pregnancy. And it includes pulmonary artery hypertension, severe systemic ventricular dysfunction. That is, all the NYHA classifications 3 and 4 will come under class 4 of modified WHO. If they've had a previous history of peripartum cardiomyopathy, severe mitral valve stenosis, Marfan syndrome with aortic dilatation greater than 45 mm, and the bicuspid aortic valve with greater than 50 mm of dilatation, and severe coarctation of aorta. So in case of modified WHO class 4, they must be counseled regarding termination of pregnancy, and they cannot proceed further with pregnancy. Yeah, so in association with this, you have to consider other risk factors, whether they are having arrhythmia, whether they are in failure, whether they have pulmonary hypertension. So all these risk factors should be considered. So this is the NYHA classification, where class 1, they will not have any limitation of physical activity. In class 2, they'll have slight limitation. And in class 3, they'll have a marked limitation in physical activity. They'll be comfortable at rest, but even an ordinary activity will result in palpitation. And class 4, they'll have dyspnea even in rest. So class 3 and class 4 are complete contraindications for pregnancy. So regarding preconceptional counseling, so once they are coming to our clinic, we must get a detailed history, review all their records. So most of these women who have been operated for congenital heart disease will have a huge record regarding follow-up and everything. So everything should be taken into consideration. We should see what all medications they are taking. And if they are taking any teratogenic medications, it should be switched to less teratogenic or other medications. And we have to do a ECG, exercise stress test, and echocardiogram. And genetic counseling up to 3 generations is required, because this is for this congenital heart disease can be further transmitted to the next generation. So they should be subjected to genetic counseling also. So next we'll be going on to antepartum. Always be managed in a tertiary care center where there's a multidisciplinary team which comprises of the obstetrician, neonatologist, anesthetist, and the very main person, the cardiologist. So they say that modified WHO class 1 and class 2 can be managed in other centers also, but right now in Tamil Nadu, we manage all cardiac disease complicating pregnancy only in a tertiary care center where there's a cardiologist who's available with the cardiac setting. So all the CHDs here in India are managed only in tertiary care center, even though they are saying, as per the American Heart Association, they are saying 1 and 2 can be managed in other centers also. So if they are presenting only in the first time in pregnancy and you're finding out that they are having an issue, we have to do all the ECG echo again must be done. And like I said, you have to revise the medications to avoid teratogenic medications. Like, for example, if they are taking any angiotensin receptor blockers or other drugs which are teratogenic, they must be switched over to less teratogenic drugs. And the most important clinch is, like we said, congenital heart disease. The baby is also prone to, if the mother has congenital heart disease, there's about 12 to 15% chance that the babies also might have congenital heart disease. So fetal echo must be done at 18 to 22 weeks. So the frequency of cardiac status is completely tailored from one patient to another, differs from one patient to another. So like we already saw in the previous presentation, the second trimester, there's maximum hemodynamic changes. So a repeat echo will be required in the second trimester. And as early as the second trimester, a delivery plan must be established, because the risk of preterm labor, risk of miscarriages are all more in the women with congenital heart disease. So we must be prepared to face whatever that's coming. So a delivery plan must be established. And they say that ACOG says that elective induction of labor is always preferred. And for logistic reasons, the delivery must happen when all the specialists are there. That is the cardiologist, the anesthetist, the neonatologist, and the entire team must be there to manage the patient. So the delivery must be planned in such a way. And they say that elective delivery before 39 weeks should be contemplated, because after 37, when you're inducing at a younger, lesser gestational age, there's more risk of cesarean. So we have to keep all the multiple factors, that is the patient status, how her cardiac status is, and the other factors, and decide when to induce her. So this here we can see that how many times the woman should undergo a follow-up with a cardiologist. So in modified WHO 1, at least once or twice in the pregnancy, she follow up with the cardiologist. In WHO 2, at least once per trimester. In 3 bi-monthly, in 2 to 3 bi-monthly, in 3 monthly or bi-monthly, and 4 monthly. But in India, 3 and 4, we do not ask them, we counsel them regarding the risk-benefit ratio, and mostly all the 3 and 4 go for termination only here in India. So the labor care, the woman must deliver in the right or left lateral tilt. Vaginal delivery is preferred with adequate analgesia, or epidural analgesia can be given. Cesarean should be done only for obstetric indication, and Valsalva maneuvers should be discouraged because it increases the pressure further, which is not acceptable. And similarly, we should cut short the second stage of labor by forceps or vacuum once the head comes to the outlet. In case of cesarean, epidural anesthesia is preferred over general anesthesia. Spinal anesthesia is not preferred because there's a rapid drop in blood pressure following spinal anesthesia. So we can use intravenous crystalloids for hydration, closely monitor the fluid balance. If the woman is having right to left shunt, filtered vascular line should be given, continuous SpO2 monitoring and vital monitoring. And if she's had a previous history of arrhythmias, we must do ECG monitoring also. If she's developed congestive heart failure, then we must do put in a central venous catheter to monitor for volume overload also. So postpartum care is a time where the risk of failure is more. So this period from 6 weeks to 12 weeks, we must monitor her. We must keep her, explain her regarding all the danger signs and symptoms, and she must be monitored at least for 24 hours in a cardiac ICU. That is a modified WHO 2 and 2 to 3 must be monitored in a cardiac ICU for 24 hours. And early ambulation is advised. And in the review visits, postpartum care and cardiac evaluation by repeat echo is done. So she should also, like I said, she should be educated about the danger signs and symptoms. So regarding antibiotic prophylaxis, AHA, that is American Heart Association, does not recommend routine antibiotic prophylaxis, but in case of complex congenital heart disease, they advise a single dose of ampicillin 2 gram IV stat or ceftriaxone 1 gram IV stat 30 to 60 minutes before the procedure, that is vaginal delivery or cesarean. And ACOG also does not recommend routine bacterial endocarditis antibiotic prophylaxis. So this is the most important part, contraception. So based on FSRH guidelines and the UK MEC, oral contraceptive pills can be given in case of uncomplicated CHT, but it is contraindicated in complicated CHT. If they are having previous history of venous embolism, then it is completely contraindicated. Then LNG-IUS is in uncomplicated CHT, it can be given, and in complicated CHT, the benefits outweigh the risk. Progesterone only pill can be safely given both in uncomplicated and complicated CHT. So same as in progesterone implants. So DMPA also can be safely given both in uncomplicated and complicated CHTs. So the copper IUD in uncomplicated CHTs, it is class 1, but in class 2, in complicated CHT, the benefits outweigh the risks, so it can be given. So the other complications which we commonly encounter in a case of congenital heart disease, if it's atrial flutter or fibrillation, the metoprolol can be used. In ventricular tachyarrhythmias, metoprolol or IV lidocaine can be used. In case of AV block, pacemaker can be placed, but in echocardiography guidance. And in case of any mechanical valves which are there, anticoagulation with low molecular weight heparin should be given. So warfarin can be switched over to low molecular weight heparin in pregnancy. So in case of cyanosis which develops new onset in pregnancy, we should definitely proceed with termination of pregnancy because it has bad prognosis. So I'm moving on to specific lesions. I'm just going to tell in a gist. So all the shunt lesions, ASD, VSD, AVSD, if they are completely repaired, they fall under category 1 only. But if they are unrepaired and the woman proceeds to pregnancy, there's increased risk of atrial arrhythmias and about 10% risk of congenital heart disease in the children. In case of pulmonary valve stenosis, the right side heart obstructions are well tolerated in pregnancy, but similarly, the complications like premature delivery, premature labor, and FGR are more prominent. And in aortic stenosis, severe left ventricular outflow obstruction is definitely a contraindication of pregnancy. and the lesion should be corrected before the pregnancy. So, and also congenital aortic stenosis due to bicuspid aortic stenosis is associated with aortic dilatation and dissection. So if this condition is there also, the pregnancy is contraindicated and surgery must be done prior to the pregnancy. So in tetralogy of Fallot, pregnancy is well tolerated, but there's always a risk of arrhythmia and heart failure and an increased risk of FGR. In transposition of great arteries, the surgery which is done is switch surgery, but even though the switch surgery is done, there is increased risk of complications like preterm and FGR. In Marfan syndrome with aortic dilatation greater than 45 mm or in vascular Ehlers-Danlos syndrome, the pregnancy is contraindicated and hence must be terminated. For compensation is where there's a single functional ventricle, that is hypoplastic ventricle is there. So there's increased risk of thromboembolism and atrial arrhythmias, and pregnancy is contraindicated. It falls under class 3 and 4. So cyanotic lesions have a very increased rate of miscarriages and FGR, up to 90%, less than 90% rate of FGR and premature birth because of the cyanosis. So these women should be counseled against pregnancy, and there is very little literature also regarding pregnancy in cyanotic women. So, to add on regarding termination of pregnancy in first trimester, surgical evacuation of pregnancy is also safe, and misoprostol can be used for induction, but it should be done only in hospital setup and not in the home, not at home, because the patient must be monitored because of the increased risk of hemorrhages. So second trimester termination of pregnancy is also, we can use misoprostol, and the patient must be carefully monitored because the second trimester, already the hemodynamic changes have set in. So they must be monitored with caution when we are sitting with MPP. So I hope I was able to cover everything. Thank you for the opportunity.
Thank you, Dr. Bhumika. So you said that you have to have preconceptional counseling, especially in women with congenital heart disease prior to pregnancy. What's the incidence of the risk for the fetus when there is the mother is?
There, in case of ASD, VSD, and AVSD, the risk is about 15%, ma'am. That the fetus also has the congenital malformation.
Oh, that's quite high. It's not as high as 15%. Probably most of the books say it's about 3% and maybe up to 10%. So when would you recommend doing a screening or an echo for the fetus? In women with the congenital heart disease when they are carrying the pregnancy.
At 18 weeks, we can advise them fetal echo, ma'am.
Though we can have a major look at 18 weeks, but ideal will be to look at between 22 to 24 weeks. Yes, that's the time that they will be able to pick up the lesions. But now with the increased the improvement in our scanning techniques, they are able to pick it up even at 18 weeks. But for some of the evolving lesions, especially the structural septal defects and all, it's much better when we do the fetal echo at 22 weeks. And what is this entity called cor triatriatum? Any idea what type of a congenital anomaly that is? Cor triatriatum. Am I audible? Cor triatriatum.
Cor triatriatum. I'm sorry, ma'am.
As it is actually self-explanatory, the atria in the women will be separated. It can be either dexter or sinister, depending on the presence of a membrane in the right atrium, which divides it into two separate cavities, or sinister in the left atrium. The membrane separates it into two cavities. So they have a triple atria, so as to speak. Because this was one of the presentations in one of our OGSI webinars, where they have talked about a woman presenting with or triatriatum. Thank you, Dr. Bhumika. Thank you for your presentation.
Thank you.
Yeah.
Thank you. Thank you. I welcome Dr. Jaydeep Tank. Welcome you, sir. Radhika?
Yeah, good evening, ma'am.
Good evening. Good evening.
Radhika ma'am,
you are muted.
Okay.
Sorry.
I welcome. It's my great pleasure to welcome Dr. Jaydeep Tank, our chief guest for today's marathon CME of TNFOG. Sir, for information, this marathon CME is conducted every month on the first Friday, in which two Yuva speakers are given the chance to talk about the basics, and the two judges are there throughout this year. And also, we are having the seniors to talk about the other aspects of the same problem. And alternatively, we have both obstetric as well as gynec topics. And at the end, we are involving all our members to participate in a panel discussion on practical management of that particular problem. So this is for your kind information. And it's my great pleasure to introduce our President-elect FOGSI, Dr. Jaydeep Tank. He's the Secretary General. He was the Secretary General of FOGSI from 2018 to 21. Project lead FOGSI USAID projects 2024. Past President Mumbai OG Society. Deputy Secretary of Asia Oceania Federation of AOFOG, immediate past chair International Federation of that is FIGO Committee chair for safe abortion, has been awarded FSCOG honorarium, and past chair Publication and Newsletter Committee AOFOG, past chair Reproductive Endocrinology and Infertility Committee AOFOG, past chair of MTP Committee FOGSI also. And every one of us know him for his digital work. He has done a lot for FOGSI. And digital election was the brainchild of Dr. Jaydeep Tank. And he's at present consultant Aswini Maternity and Surgical Hospital Center for Endoscopy and IVF, co-founder Esperanza Healthcare Private Limited, program director and member of board Profit IVF, and visiting consultant for IVF at more than a dozen of IVF centers. It's a great pleasure to welcome you, sir. And I welcome you to say a few words to bless us.
Thank you. Thank you very much, Nancy Madam, for that very kind, warm and generous introduction, as always. I'm first must apologize for joining very, very late. I'm sorry, I got caught up in a bit of an emergency and I couldn't leave and, join the CME, but that's what an obstetrician's life is, I suppose. I am very happy to be here. It's a pleasure and a privilege. And I must thank Dr. Revati Madam, who is the president of the TNFOG, and Dr. Sampath Kumari. I see Dr. Sampath Kumari traveling by car somewhere. Always a pleasure to meet Madam. And she is, of course, the secretary, and Dr. Vijay Lakshmi, who is the treasurer. It is, of course, a privilege to share the platform with the guest of honor, Dr. Anjalakshi. I had done quite a lot of webinars with the TNFOG in COVID, and I'm very happy that the initiative is carrying on so well. I have always thought that the TNFOG is a great example of what a state federation should be like, and the educational activities which a state federation can do. I must also thank and congratulate all the faculty, and Madam, the topics that you have picked are really excellent. It is such an important topic. I feel that we are now taking heart disease a little for granted, but we also need to now start looking beyond the classical rheumatic heart diseases of the yore, where we had all those MRs and MVPs and all that kind of stuff, and now we need to start looking at other things. And I'm happy that Dr. Nidhi Sharma and Dr. Vijay Lakshmi are the judges, and the Yuva presenters are Dr. Divya and Dr. Bhumika. And then, of course, there is this very important lecture by Dr. Paul on cardiac registry, chaired by Dr. Manomani. I'm very happy to see you, Madam. I remember the wonderful CME we did in Coimbatore. And of course, you have a panel on heart disease in pregnancy case scenarios moderated by Dr. Chitra with Dr. Vaishnavi, Dr. Rosie, Dr. Radhika, Dr. Vijaya, Dr. Devi Lakshmi, and Dr. Nega as the panelists. Lastly, I know it's not always easy to be an MOC. So Dr. Radhika, thank you very much
Thank you.
for all your efforts. And again, let me wish the TNFOG all the best. It's always a pleasure and a privilege to be here. And I must again apologize for joining late. I'm really sorry about that.
Thank you, sir. Thank you so much.
Thank you.
Yes.
Thank you,
We
sir.
will invite
Next
you in
year
a
also, we
physical
expect the same support for TNFOG.
Of course.
Sir, we will invite you in a physical meeting, TNFOG annual conference.
Absolutely, madam. My privilege. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you, sir. Thank you for your blessings and wishes. Thank you, Revati ma'am and Sampath ma'am. We'll move on to the next session by Dr. Justin Paul, sir, about the cardiac registry. Dr. Manoni ma'am. She is the professor and HOD of Department of OG in Coimbatore Medical College Hospital. And she's been serving there for the...
Thank you. I'll introduce her. Thank you for the thank you for the kind words.
Okay, ma'am.
So, good evening, one and all present here. It is my proud privilege to introduce Dr. Justin Palsa, who is Professor, Institute of Cardiology from prestigious Madras Medical College, my alma mater. Yes, held positions as State Nodal Officer, Heart Disease Management Program, Tamil Nadu is a Board of Studies in Super Specialty Courses, Dr. MJ Medical University, and is member Board of Studies, School of Philosophy in Madras University, and his academics in areas of interest. He had developed interventional cardiology in Government Stanley Hospital, developed interventional cardiology in Multispecialty Hospital, Lomandura, developing STEMI management program at 84 crores for Tamil Nadu government. He is the principal investigator for pregnancy heart disease registries, MPAC and TNPHDR, more than 100 publications of papers, international and national journals and conferences. I am very proud to be part of this Tamil Nadu pregnant women with heart disease registry. We are also one of the centers. I thank Dr. Justin Paul for involving us also in that program. And I think we are going to start with the National Pregnancy Heart Disease Cardiology thing in coming future. So welcome you, sir. Thank you.
Thank you very much, madam, for the very kind words of introduction, and thank you, Foxy, for having me. And I think when Dr. Sampath Kumari called me and asked me to talk, the moment I immediately said I will agree, and somehow I had forgotten till today when I was reminded in the afternoon that I need to talk. So I somehow managed to reach the place between driving, and my assistant, Dr. Annie, had helped me to send some of my slides back here. The topic given to me is registries, of pregnancy in heart disease. Now, first of all, why do we need to have a registry in heart disease? There is something we really need to think about it. So for that, probably I'll just take you for a brief overview of some of the inputs that probably we can have. Am I visible? Is my slide seen?
Yes, sir.
Yes, sir.
Okay. So now you
Slide
can
show
see
format.
Yeah, now is it a slideshow? You can see that then this is the number of mothers who die per thousands per year. So you find in India, almost 35,000 mothers have been dying per year. And if you look at another chart from again World Bank, we find that we are second to Nigeria in terms of the number of mothers who die during pregnancy. If we compare our population and Chinese population, in China, 14,000 mothers died due to heart disease. So we're working very hard, and we are bringing down our maternal mortality. This is one chart that I would like you to remember. The green chart is the one that, if the world today is like what it was in the past, we'll have 1.26 million mothers dying per year during pregnancy. But thankfully, we have improved our status to the present level, the world today, where almost 300,000 mothers die per year in pregnancy, during pregnancy. However, if we are able to provide the best class of treatment as available today, to all the mothers in the world, our maternal deaths will come down to 11,000. In other words, 290,000 mothers dying of heart disease we can prevent. And we are inching our way towards a maternal mortality rate of 70, our sustainable development goals. Well, states like Tamil Nadu, Kerala, we have reached that goal, but then there are many other states in our country which needs to look at this aspect more seriously. And I'm so thankful to Dr. Jaydeep, who said that we cannot take heart disease in pregnancy for granted. The reason being, if you look at that, why did Dr. Jaydeep make a statement like that? If you look at the number of pregnancy-related deaths in UK, you find the largest cause of death is heart disease. If you look at what is happening in US, the largest cause of death is again cardiovascular disease. If you add the cardiovascular disease and the cardiomyopathy, you almost get 25.2 mothers are dying during pregnancy because of heart diseases. If you took a cardiovascular, including thromboembolism, you almost reach 1/3 of the mothers die due to heart disease or cardiovascular disease. This is another data. This was, I think, earlier one of the slides that I gave in one of, I think, FOG Marathon only. So I'll add some newer data. This is another important inputs that we need to have. 2/3 of mothers who die due to preventable causes. Preventable causes. That is extremely important. We need to make our own data of all the mothers who die due to heart disease, say in our country per year. We need to collect all the cases and find out what are all the preventable causes. Is it patient-related causes, or the system-related causes, or the healthcare-related causes? Then how do we get all these data? This is where the registries come into play to provide our answer. This is a data I collected thanks to NHM, thanks to Dr. Shobha, who's there, and the MD NHM. What we find is in 2011 in Tamil Nadu, the cardiac contribution to maternal mortality was 4.56, whereas in 2021, the latest data is 11.3%, which I have not put in this slide. So, because, if you look at the maternal mortality of Sweden, Norway, and Finland, it is 5 to 8. And of almost all of these are due to heart diseases. This is what you all call obstetric transition, where over a period of time, as the overall healthcare improves, the maternal mortality shifts from indirect causes to direct causes, of which cardiovascular disease is the largest cause. Science can tell us what can be done, guidelines tell us what should be done, and registries only can tell us what is being done. Unless we know what is being done, we cannot plan to reach where we want to go. That is where the registries come. These are some of the registries in the West Sahara study and the CARE2 study. And, these are some of the data from India, where we have most of them have been retrospective. Thankfully, we were able to have this, Madras Medical College Pregnancy and Cardiac Registry conducted over a period of time, thanks to so many logicians who are adorning FOGSI today, and so many cardiologists. And what we could present that earlier, and maybe I'll show some of the recent slides. 1 minute. So we started this registry. Am I showing this? Are you able to see the slide?
You can see.
Yes, sir, but slideshow.
Yeah, so this is where we started the largest prospective registry, a single center registry in the world. This MPAC registry, what we started in Madras Medical College, has 1,005 women with 1,029 pregnancies. So this was one of the slide introduction that was presented in South Africa about our study in the Hatter Institute by Dr. Karen Sleva, who is authority of peripartum cardiomyopathy. I'm so happy to say that our study is being presented as journal club across the world. So I should thank all the physicians involved in this program. So out of the 152,000 pregnancies, we had finally included 1,029 pregnancies. And what we found was 50.2% had cardiac events and 1.9 had maternal mortality. This is pretty high compared to the other registries. And, 1/3 of them had adverse fetal events. If you look at the largest cause of maternal mortality, prosthetic heart disease, pulmonary hypertension, left ventricular dysfunction come into the picture. You find that the maternal mortality almost ranges from 8.6, 1.9, and 4.8. Another important finding that we found in this registry is that there's a current pregnancy diagnosis of heart disease. Many women, they end up knowing that they have a heart disease only during the pregnancy. Almost 60% of women knew that they had a heart disease for the first time in pregnancy. This is due to multiple reasons where patient may not have diagnosed, or the patient would have been diagnosed, would have been told to the parents would not have told to the children, and for the first time it got diagnosed. There are multiple reasons behind the shame and the complexities behind knowing to have a heart disease. These are all some of the issues that our society faces. We really need to support our women who go through pregnancy, who go through all the troubled times of pregnancy. Now, if you ask my assistant professor, Dr. Annie, she will tell you stories and stories of women crying. In fact, I'm involved in most of these women, thankfully, with Dr. Annie. Many of them have gone through domestic violence. We did a small study on women with prosthetic heart valves. The struggles they go through is phenomenal. We really, really need to support them so that they go through the pregnancy. The dream of every woman is to become a mother at least at a point of time. And we really need to support these women and ensure that we support these women to become a mother as much as possible, as long as we can safely protect the life of the mother. The key findings of our study include the first diagnosis of heart disease in pregnancy was 60%, of which RHD was most common, followed by congenital heart diseases. This percentage may be reversed in larger institutes where they are catering to predominantly congenital heart diseases, but however, predominantly in the government setting and in the public health settings, it will be rheumatic heart disease and valvular heart disease will dominate. And the heart failure, maternal heart failure, is the commonest complication during pregnancy. So what we really want to the low middle income countries like our nation is to focus on the nation and the FOGC and the Cardiology Society of India, Indian Society of Cardiology, or Indian College of Cardiology. More importantly, the National Health Mission has to focus on developing this field of cardio-obstetrics. Because what we really find is most of the physicians, most of the cardiologists may not be focused on improving their knowledge in this particular area. Our cardiologists may be focused on developing, their knowledge on complex coronary interventions, complex structural interventions, and probably physicians may be focusing on latest in the in vitro fertilization and all those kind of stuffs. I'm not too sure how many of them, including our side or physician side or anesthetist side, are keen on increasing their knowledge in cardio-obstetrics. The reason why I say that is, despite the best care in the best of the settings, 2/3 of the women who died of heart disease during pregnancy, the death could have been prevented by an alternate method of treatment. So that would mean that the knowledge base is less. We really need to create cardio-obstetrics societies. We really need to create a curriculum for cardio-obstetrics, some fellowship programs in cardio-obstetrics. We need to develop early diagnosis and preconception counseling. We need to offer lesion-specific counseling and care. These are the importance of heart disease complicating pregnancy. And another slide that probably I'll show is that this is one slide published in the European Heart Journal. This was a review by one of the leading cardio-obstetric personalities in the world, Dr. Rose. She has compared all the 3 major registries in the world. the MPAC, the ROPAC, and the CARE-PREG. And what we find is our maternal mortality is 1.9, whereas in CARE-PREG and ROPAC, it is 0.5 to 0.6. But however, if you look at the complexity of our patients, we had higher number of patients in modified WHO 3 and modified WHO 4 compared to CARE-PREG and ROPAC, as you can see in this particular slide, in this portion, the last two. So we had higher risk patients, but however, still our mortality was very high. And most of the time, as seen in all the studies, heart failure is a commonest complication. However, in CARE-PREG, where congenital heart diseases were the commonest cause, arrhythmia was the commonest complication of pregnancy. So, well, now this is about Tamil Nadu Pregnancy and Cardiac Registry. Most of you are partners with us, Dr. Manohar. I mean, she just spoke to, about me, introduced about me. Thank you, madam. And I think I should thank I can't keep on naming the physicians, the interest they show, the passion they show, the desire they show to cooperate and collect data. Thankfully, we have completed the enrollment of 2,995 patients, and we have completed the follow-up of, this is the oldest slide, we have completed the follow-up of almost, except 30-40 patients, we have completed the follow-up, and we are cleaning the data. So we have to analyze and present our data. This will be data of the whole state. This is going to throw in more lights where we can, find out what are the gaps that we have. Meanwhile, we are also in the process of creating a national pregnancy and cardiac registry called NPAC study, where almost 40 sites have shown interest in joining the registry. It will be slightly more different. Hopefully, we'll get funding from the funding agencies, but the thought process is different. What we are looking at is we are creating a cardio-obstetric protocol, and it will be a cluster randomized study of cities, centers randomized to usual care versus center randomized to cardio-obstetric care. It will be a randomization process. So this is a study that we are working on, and some of you are really, I'm thankful to some of the centers. We have planned 55 sites across 26 states in our country have shown interest, but we have to choose only 40 sites based on their cardio-obstetric volume. So we are looking at that aspect. So thus, the importance of a registry looks at is that it tells us where we are, what we lack, what are the gaps that we have. Then only we can plan on how to sort out the gaps. We really need to work very closely with Foxy, and I'm so thankful to you for calling us. And we are working in the process of creating some position statements and guidance statements as well for various disease process, particularly prosthetic heart valves, where so many women die. Heart failure in pregnancy, where so many women die. We really need to prevent all these women from dying. And if India has to reduce the maternal mortality, let me tell you very clearly, the nation has to focus on bringing down the mortality related to cardiovascular disease in pregnancy. And I want you to be all ambassadors wherever you go to create the field of cardio-obstetrics, to strengthen the field of cardio-obstetrics, and partner with one another to develop the data, to see what we can do, because unless we have data, we really cannot build up our own guidelines. The Western data is not going to help us because it's completely different. It is in a different socioeconomic scenario, it is in a different medical scenario, and it is in a, they have a different kind of heart disease profile as well. Whereas in India, we have a different kind of socioeconomic scenario. We have a different healthcare facility scenario and a different heart disease profile scenario. So that is the importance of developing pan-national registry. And I thank you very much, madam, for the opportunity that you have provided me for sharing my thought process and our data. And I'm so sorry I could not plan organized slide presentation. I thank you very much once again.
Thank you, sir.
Tell Manohar, you talk.
Thank you, sir. It was a wonderful presentation, and we could see how much work has been put on that registry and how many centers were involved, and actually how much you make us involved in that study. so that you have been guiding us and telling us what is to be done and sending all the guidelines and how to fill it up, all the forms, and get back and coordinate with the cardiologists and obstetricians and all the sites. And we are very happy to be part of that study. We are anticipating the study results as it comes in complete format. And we'll be happy to be part of NPAC study also. So it was one wonderful study done at MM Singh, sir. So it is we're very happy that it has been acclaimed all over the world. Thank you so much. Thank you, sir.
All over India first.
It's my NPAC study and the MMC study.
Sir is interested with Foxy. With the Foxy, he is interested to do with all. I told him we will talk to the president. Anyway, Sir is doing a wonderful work. Thank you.
Actually, visited all the centers by personally and motivate us to get involved in this. So that is the involvement Sir has shown.
Sir, Paul sir, yesterday, Justin sir, I was trying to call you, but somewhere other call was not going. That's the reason I missed you. Otherwise, yesterday I would have given the remember.
It is my fault, madam. I should have remembered that I had agreed to you. It's not your fault. It's my fault.
Yesterday twice I called you, but I couldn't reach you. I should have tried today morning. Anyway, sorry for that. Thank you, sir. Thank you so much.
Thank you, sir. And thank you, madam. Manonmani ma'am, and thank you, Paul, sir.
Thank you.
Now, the next session is panel discussion on heart disease in pregnancy, case scenarios. I invite Dr. Chitra ma'am, professor who is the professor and unit head of PSGI MSR, Coimbatore, Tamil Nadu. She's the
Make it short. Radhika, make it short.
Okay, ma'am. She's been a teacher for 20 years, PG coordinator, has conducted PG refresher courses and maintained in-depth, up-to-date subject knowledge, aiding site innovative curriculum development and teachings. And she's created presentations to deliver lecture material in classroom and online environments. She's a ICOG, JUGA, IUSOG member, trained in urogynecology in KK Hospital, Singapore. And she's worked with Dr. Rajameshwari ma'am, urogynecologist in Chennai. And also she's a certified colposcopist interested in very high-risk pregnancies and PG training programs. And she's been the past president of Kovai OG Society, scientific chair to various conferences. She's won the Best Teacher Award by the institution. Welcome, ma'am.
Thank you. Thank you.
Thank you.
Will you introduce the panelists?
Panelists, yes, ma'am.
Okay.
Shall I? Dr. T.M. Vaishnavi. She's alumni from Tanjavur Medical College. She's done her Obs and Gynae from Stanley Medical College. She's trained in laparoscopic gynae surgery, experienced handling high-risk cases in both Obs and Gynae, worked in a reputed private hospital as an associate under the guidance of senior well-known gynecologists, currently working as assistant professor in Sri Muthukumaran Medical College, Bangadu, Chennai. Her special skills are laparoscopic surgery and emergency obstetric management, family planning, and sterilization. Welcome, Dr. Vaishnavi. Dr. Josephine Rossi is an alumni from SRMC and RI, and MDOG. She's done her MDOG from Annamalai University, MRCOG from RCOG London in 2022, and CCGDM and CAMP, and she's assistant professor of Obs and Gynae between 2010 to 2015, and HOD and professor of OG in 2020 until now. She has e-post representation RCOG in 2020, has published 2 national and 2 international journals. Okay, Dr. B. Vijaya, she's done her MBBS from Madurai Medical College, 1996, and a postgraduate. She's a postgraduate from Gosha, I think. She's cleared her diploma in Depend B exam in 2010 and diploma in laparoscopic surgery in 2015, and she's published case studies in international journals. She's got the Best Doctor Award from state government in Tamil Nadu, state government service for 23 years, and she's now associate professor of Obs and Gynae, Dindigul Medical College. Welcome, Vijaya ma'am. And Dr. A. Devi Lakshmi, the assistant professor in government Karur Medical College Hospital and also consultant in Renu Hospital, Karur. Her field of interest of laparoscopy and high-risk obstetrics. Dr. Nagasudha, the Assistant Professor of Department of Gynae, Madurai. Welcome, Dr. Nagasna.
Can I share my slide?
Yes, ma'am.
Oh, okay. Wait. But you have to close your slide. Okay, is it seen?
Yes, ma'am.
Yes,
Radhika,
ma'am.
seen. Okay.
In, ma'am.
At the outset, let me thank TNFOG for having given me this opportunity. Having listened to just Paul, was really an excellent presentation. So all the more, it's very important that we briefly know about heart disease in pregnancy, because as I said, I fully agree with sir, because the commonest cause of maternal death, especially if it comes to direct cause, is going to be heart disease. Like I said, many people are dying because of heart disease. And the other thing that sir said was, many often we only diagnose it during pregnancy. That is very, very important. And more than that, sometimes we miss the case during pregnancy. That is also equally important, because we have forgotten to put our stethoscope on the patient. And so it's very important that we might be the only persons to diagnose it first. So straight away, coming to panel discussion, I welcome all the panelists, Dr. Vaishnavi, Josephine, Radhika, Vicha, Madam Deepa. Deepa Mangalam is not there, I think. Has Deepa Mangalam joined?
No, ma'am.
And Nagasudha for this panel discussion. So I would, because it's so vast, I thought I'd just touch upon certain points which I thought would be very practical from in our day-to-day activities. So I would only talk about certain things. When all will you suspect heart disease? How will you diagnose heart disease? A little bit about pre-pregnancy counseling. What are the indications when you will terminate and how you will terminate? And I will just have a case scenario, because the time allotted is only half an hour. Okay. So coming straight to the first question. Can I ask Dr. Vaishnavi to talk about what are the clinical history and examination findings to suspect a heart disease? Because when all will you think, because there are so many patients coming to you in a busy OPD, but when will you have a suspicion that this particular person might be suffering from heart disease? And on examination, what should be the findings to make you suspect that it is a heart disease? Vaishnavi, please.
Yes, ma'am. Good evening, ma'am. I'm here.
Yeah, Vaishnavi,
And
welcome.
first of all, I thank you all for giving me this opportunity. And for a patient who's coming to the OPD, the suspicion of heart disease is like, it's a little tricky, because most of the symptoms of heart disease will be somewhat similar to the symptoms of pregnancy, like fatigue and dyspnea, like that. But once a patient says that she's having dyspnea, like it is progressive, that was not like it used to be before, and fatigability that is gradually increasing, and chest pain, palpitations, and syncopal attacks and symptoms of that sort, then will be more suspicious of heart disease. Whether symptomatic or not, we have to examine the patient, keeping in mind that she could be having some unmasked heart ailment. And the clinical findings that would be more suggestive of a heart disease would be systolic, on auscultation, a systolic murmur that has a grade of more than 3 to 6, and palpable murmurs, and any signs of congenital heart disease like cyanosis and clubbing should be looked for. And heart rate, the rhythm would be is something that we should keep in mind when we look for the pulse rate. And if you're able to pick up any missed beats or any arrhythmia, then we should probe more into the finding of a heart disease in the patient.
Okay, thank you. There's only one more thing. Whenever you have to, the rhythm alone is not enough. It's also important that you are able to feel the peripheral pulses in all the 4 limbs. That is very, very important, because
Yes,
sometimes
palpation of aorta,
so it's very important that we palpate everywhere, because a patient sometimes on the theater we find that she's had a tachycardia. So it should not happen. So that is important. And the suspicion for heart disease, like you said, the symptoms are the same. But whenever you have a diastolic murmur, I think because in enumerating things, a diastolic murmur is very significant. And a grade 3 systolic murmur is again very important. Okay. So now that you've suspected that it is a heart disease, I'm sure you're going to refer it to a cardiologist. What do you think would be the investigation? Because now there is so much which is being updated about investigations in the case of suspected heart disease. Can I ask Josephine, doctor, to enlighten us about this? Dr. Josephine?
Basically, any patient with suspected heart disease, we would like to do basic ECG and an echo in all pregnant women universally in order to find out any lesions, ma'am.
Okay.
These are the basic investigation we would like to advise.
Okay. So in addition, there is something known as an exercise testing. Once you diagnose that this particular person is having some heart disease, you can do two more things. An exercise testing, which is not like the ordinary techniques that we do, but they only use about 70% of things that, that much of exercise only is being done. And in suspected cases, MRI also is coming up in a large way. Now, initially, we were only thinking of ECG initially, then we moved on from ECG to echo. But now from echo, they're moving on to MRI also, which can be done in a case which is complex, etc. Then they say you can do an MRI also.
Okay.
Now, the next question. In a person with a known case of heart disease who is contemplating on pregnancy, how should we counsel? Suppose you know that this particular person already has a heart disease. So there are certain things that you advise her. So how will you examine her and what are the advice that you tell her? Can we ask, have Dr. Vijaya to talk on that?
Yes, ma'am. Good evening, ma'am.
Am I audible, ma'am? Yeah. So when a person who's a known case of heart disease, which wants to get pregnant, so what will be your advice and how will you tell her? What all will you tell her? What all will you see?
I want to thank all for giving me this opportunity, ma'am. First of all, the patient with heart disease coming to me for counseling means, first I'll take a detailed history of her, all the history you told, all the history, and I'll evaluate it, and I'll come to a proper conclusion about that pregnancy, and I'll counsel the patient, and I'll tell the pregnant mother and her family regarding the maternal risks. What are all the risks she's going to undergo in this pregnancy? And and also the fetal complications. What will be going to happen to the fetus? And what is the risk of congenital heart disease in the fetus? And about the 4Ds and all, heart failure, and where we are planning the pregnancy and how we are going to manage that pregnancy, and whether if it is any severe NIHA heart test, NIHA class 3 or 4, and if it is in severe pregnancy, we have also to advise for the termination of pregnancy for that patient. We have to advise all the risks of maternal risk and fetal complication, and the risk of congenital heart disease, and if there is any, and the plan of treatment and plan for the tertiary care. We have to advise the place and the cardiologist team what are all the risks we have to undergo. I'll counsel all about that to the patient, ma'am.
Thank you, Vijay. Very well said. And especially the one word that you said about family. It is just not important if you involve the patients. Very important that you educate the family, because that might be a shock to them. Unless you tell them that this particular thing will happen to the baby and the mother, they will not give the entire support. So it's important that you involve the entire family. That's excellently said. Now, is there anything else, Dr. Devi, that you would like to add when you talk about this counseling? Like she said, you have to tell about the complication which can happen to the mother, the complication the fetus is going to happen. Anything else you will also assess? What is the NIHA classification that she said? Anything else that you would like to tell her before she gets pregnant?
We need to find out if she's, good evening, madam. We need to find out if she's really fit to undergo pregnancy or not.
Exactly, because what is the class? What's the class? Suppose she's 3 or 4, then you may tell her to become better. And anything else? Nagasudha, anything else would you like to know? Anybody else would they like to add?
We have to change the
Vaishnavi? Yeah.
If there is any corrective surgery needed, it can be
very
done.
Good. Suppose if she's having any surgery which requires correction, suppose you know that she's having severe mitral stenosis, then maybe you could correct surgery and then plan for a pregnancy, isn't it? So that's the other thing that you must do in counseling. Anything else, Dr. Devi Lakshmi, anything else would you like to add?
Then we have to change the drugs, like if AC inhibitors are contraindicated, that has to be stopped, and some drugs which is not contraindicated can be switched over, madam.
Very good. So that also, because most often nowadays we see patients who are becoming, who because of the age, we see them getting pregnant with a heart disease in pregnancy. So if she's on certain drugs, then maybe you have to see what the drugs are and change over to drugs which are important. Which are not so very toxic, which they might be on statins if they're having hypertension, or like she said, ARB drugs, etc., should be changed. Okay, so at the first visit, you must first find out is she fit to undergo pregnancy. If not, or if there's any lesion which requires correction, that should be done. And explain to her in detail about the pregnancy complications and the maternal complications. I think all of that you have said already. So next. Dr. Nagasudha, is there any condition where pregnancy cannot be undertaken, where you find out that this person is best that she does not have this pregnancy? Is there any condition like that?
Yes, madam. All the class, WHO class 4 conditions are contraindicated in pregnancies. That is, these
Can you just name the common
yes,
ones that we come across?
Yes, madam. Primary pulmonary hypertension, severe ejection fraction less than 30%, previous peripartum cardiomyopathy with residual lesions, severe mitral stenosis, severe symptomatic aortic stenosis, Marfan's with aortic root dilatation more than 45 millimeters, Eisenmenger's syndrome, severe coarctation of aorta, Fontaines with complications, and aortic valve, bicuspid aortic valve where it is more than 50 mm, Turner's with ASI more than 25 mm, tetralogy of Fallot more than 50 mm. These are all the contraindications of pregnancy, where we have to find out all the things, and we should advise them not to become pregnant. And if found to be pregnant, we have to advise termination in first trimester itself.
So basically, all patients belonging to modified class 4, WHO class 4 should not undergo a pregnancy. Okay, so the common things, like she said, if it's a severe mitral stenosis or aortic stenosis, then it's better that you, critical cases, you better that you don't undergo pregnancy. Similarly, your primary pulmonary
hypertension. Class 3 and 4.
Yeah, okay. Oh. Then supposing you find that she requires a termination, we are always confused. Will this drug have any side effect? Are we going to do a surgical method, or are we going to do a medical method? Can Dr. Josephine take up this question?
Ma'am, both are actually for termination of pregnancy. Both methods are equally safe and effective.
Which is better?
So, okay, rather than medical, we have to advise a hospital termination. For surgical, we have to take concurrence with a cardiologist and anesthetist. We have to take opinion from everybody. Basically, the patient is fit for surgical, we can continue with surgical. But we have to explain about the risks of termination of pregnancy also, ma'am.
Is it, suppose you do a medical termination of pregnancy in the hospital, is there any change in the drug? Because we do not know, will when you give misoprostol or mifepristone, will something happen to the patient, or do we need to change the drug? Can this be given? Can it not be given? Is there any change?
No, usually we can proceed on with the routine misoprostol dosage. I don't think there is any changes to it required, ma'am. But
because
probably
they're always getting tensed, isn't it? Can we do this or not? So, but basically, like she said, the schedule is the same. We don't follow it. There is no contraindications for any of these drugs. Okay. Now, I thought I'll just have a case discussion. Now, this is Mrs. X. She's a gravida 2, para 1. She's a known case of aortic valve replacement on warfarin therapy. She's alternating between 3 and 2 milligrams. She's come with a positive pregnancy. So, come at 7 weeks is a positive pregnancy test. Now, this particular person was having a valve replacement. If you saw Dr. Justin's chart, is that valve replacement one of the most important causes of maternal death because of cardiac disease, because of valve replacement. All patients having a prosthetic valve. So I thought we'll have this case because so many patients we see coming with a valve replacement. So I thought I'd just take up this case because it's so very, very common and it's very important. So under which modified WHO classification does she come under, and how will you predict her outcome in pregnancy? Vaishnavi?
Class 3 or 2 or 3, because,
isn't it? Yeah, she becomes class 3. Like she said, all prosthetic valve, it becomes
Class 3, ma'am.
Now, how will you predict her outcome in pregnancy?
There is a risk classification for WHO from the WHO for stratification of patients. So this particular mechanical valve replacement patient will be coming under 3, ma'am, which is significantly increased mortality during pregnancy. So we have to consider her. She needs extensive monitoring, and depending upon her, she's a gravida too. Depending upon her wish, then we should probably advise her to undergo termination of pregnancy.
Okay. But the first pregnancy was totally normal. Okay. Now, she's come. She wants to have this pregnancy. She's had the valve replaced in 2013. She's had one pregnancy in 2017, which went on uneventfully. Now this is the second time that she's getting pregnant. Now she's on warfarin. Now, what are all the complications? I told you that the dose was 3 milligrams. Okay. Now, earlier on we used to think that once you give the patient warfarin, or when she's contemplating on pregnancy, you have to stop warfarin and then change over to heparin. That is what we want, isn't it? So now, for this particular person who's on 3 milligrams warfarin, what are the options for her in the first trimester? Yes, Nagasudha.
We have 3 options, madam.
What about Nagasudha? Can I have Nagasudha?
Ma'am, I am there only, but the name is written as Vaishnavi. Sorry, madam.
Oh. Then who is the one in pink sari?
I am Vaishnavi, ma'am.
You're Vaishnavi.
The name is
I am Vaishnavi, madam.
You're Vaishnavi. So I want the real Vaishnavi to talk. Yeah, because every time I'm saying Nagasudha, okay, come.
I just answered the previous question, ma'am. So I'll take this question also.
Yeah,
options of anticoagulation, like you said, specifically the warfarin dosage is 3 milligram. The risk of embryopathy is more when it is more than 5 milligram. So depending upon the risk and benefits, and she's having a mechanical valve, we can.
Yeah. No, I just wanted to answer. She's having if it's 3 milligram, you will say, is it a normal dose, high dose, or low dose? Because now the classification says, is she taking high dose of warfarin or is she taking low dose of warfarin? So
this is low dose.
Anything less than 5 milligrams is said to be
low dose. Yes, safe,
so
ma'am.
Having low dose. So what will be ideal? What all are the options available? What will you tell the patient? Would you tell her to continue warfarin, or you want to change over to low molecular weight heparin, or you want to give her unfractionated? What are all the options available for her?
Ma'am, options available will be, there are 3 types of regimens. Like first one will be to switch her over to unfractionated heparin and then monitor her APTT levels and keep them between.
Yeah.
Yes, ma'am. First trimester up to 12 weeks, we'll have to put her on unfractionated heparin. Switch over to warfarin from 12 to 36 weeks, and after 36 weeks, again we have to switch over to trimester. Okay. So either continue same dosage of warfarin or switch over to heparin, either unfractionated heparin or low molecular weight heparin.
Okay. So, like you said, there are 3 options. You can either continue the same warfarin because it's a low dose. Now, there are a lot of studies which say that warfarin, which is less than 5 milligrams, can be continued in the same dose. There is no need to change over. But it's very important that you tell the patients what are the risks of giving warfarin, because it's a very low dose. The chance of her having some abnormality is very, very less. And moreover, when you compare all the 3 drugs, whether it is warfarin, whether it's unfractionated heparin, or whether it's low molecular weight heparin, warfarin is the best one to prevent thromboembolism. Right now, we're only interested in the mother, that she should not have any thromboembolic manifestations. So you can tell them all the 3 options, either continue warfarin, or like she said, change over to unfractionated heparin, or you want to give her low molecular. So all these are ideal, but like I said, because it's a low dose, warfarin would be ideal. Now, Dr. Vijaya. Okay. What about anticoagulation second and third trimester? Initially, you're putting her, let's imagine you're putting her on low molecular weight heparin. What about the second and third trimester?
Second and third trimester, we have to monitor the anticoagulant effect with proper prothrombin time. And
now, what type of we'll come to monitoring later and just ask you what drug will you give her? Will you, if she's on molecular weight heparin, will you continue the same thing, or what will you do?
If it is low dose warfarin means we can continue, ma'am. If we switch out the
This
dose.
case I have to only 3 milligrams, so what will you do?
Actually, actually, we have to switch over to warfarin to unfractionated heparin at 12 weeks, around 12 weeks, ma'am.
Okay. So till the first trimester, you can, the 3 options are there. But by and large, continuing warfarin would be the best. Supposing you put her on low unfractionated heparin or low molecular weight heparin, then you change over after the 12th week to warfarin. From your low molecular weight heparin, you change over to that till the 2nd and the 3rd trimester. Okay. Now, can Dr. Josephine talk about? Yeah, anything Vijay, you want to tell something?
If we want to stop, we have to stop the warfarin at 36 weeks, ma'am.
Yeah, now we're still in the 2nd and 3rd trimester. Yeah, that 36 weeks will come later. Okay,
because around delivery, if the patient is under UPH or low molecular weight heparin means we can prevent the untoward complications like PPH and all, ma'am. Because
Vijay will come. We'll ask you later, Vijay. Okay. Now, supposing you put the patient on all these drugs, just let us know how we'll monitor the patient when she's on warfarin or when she's on heparin or when she's on low molecular weight. What will be the cutoff and what will be the test? Can Josephine answer this question? Josephine, can your video be on, Josephine?
Yes. Yes, ma'am. Yeah. Yes, ma'am. Can you see?
Yeah. No, I can't see you. I can only hear you, Josephine.
My 5G has some issues. Yeah.
Okay, doesn't matter. Just answer. Now, how will you monitor? For all the 3 things, if it's warfarin, how will you monitor? What tests will you do to monitor? If it's low molecular weight heparin, what will you do? And if it's unfractionated heparin, how will you monitor?
Okay, usually for low molecular weight heparin and heparin, we will monitor for factor 10A levels, ma'am. Usually to know its anticoagulation activity. For warfarin, we have to try and look for the same APTT levels. We have to monitor. For unfractionated heparin, also the factor 10A should be monitored.
Okay. So for unfractionated heparin and warfarin, you only monitor by PT and APTT. If it's when you put on unfractionated heparin, you have to maintain the level at least around 2 times what is normal. Okay. Now, suppose you're given low molecular weight heparin, then you monitor with your factor 10A. See, but surprisingly, though 10A is a factor which is say it should be. I don't think in many hospitals they have this factor 10A, and the level of factor 10A should be done at least 4 to 6 hours after you've given the dose. So, but basically, we don't have any way in which can monitor because even in our hospital, we don't have factor 10A, which has been there. So, for unfractured, you have to go by your PT, APT, and your INR levels. For warfarin also, it is the same PT, APT level is the one which has to be done. And it's during anticoagulation. What you must remember is you must see that the desired value is maintained. You can't have an APT level of 1 or 1.5 times or INR or of 1.5 times, which is normal. For every disease, you should have a required INR. You should be able to meet the target. So getting the best dose is, and the effective dose is more important. All these will bring down the thromboembolic manifest because whenever you have a patient with the valve, it is important that you give her the correct dose, minimize the side effects, and also prevent the thromboembolism. So maintaining the correct dose is what is very, very important. So frequent monitoring is absolutely necessary. Okay. Like I said, the levels. Okay. Now, Dr. Vijay, you were the one who said, I will stop warfarin at 36 weeks. And like you said, you want to prevent all the complications and you just start over to, yes. What will you start over to? Change over at, at 36 weeks, you said you will want to change. Yeah. Can you tell me why you want to unfractionated heparin?
Because the reversal effect is, the reversal of the warfarin effect is minimal, ma'am. But we can reverse the effect of heparin and all easily by the reverse the risk of reversal of maternal.
It takes a longer time actually. It will take a longer time. you do not know, so 36 weeks, you do not know when the patient is going to get to labor. And when a person is on warfarin, it takes a long time for the anticoagulation effect to reverse back. So it will be very difficult. So to be on the safer side, if with this, you change them over to either unfractured heparin or a low molecular weight heparin, that will be ideal.
Between this, ma'am, the low molecular weight heparin reversal is also partial with protamine comparing to fractionated heparin. So it is better to go for unfractionated heparin rather than a low molecular weight heparin around the period of labor.
Yes, very good. Because like she said, it will be better that you put them on unfractured heparin also. That is one way, but both has the advantages and disadvantages. So the one thought or one guideline is the European guidelines say from 36 weeks onwards, you change over to low molecular weight heparin or unfractured heparin. But nearing delivery, just to 36 hours prior to delivery, it is mandatory that you put them on your unfractured heparin. So from 36, it could be no more warfarin. It is only either unfractured or a low molecular weight. But nearing delivery, you have to change over to definitely unfractured heparin because you can reverse it well with your protamine sulfate, and it's very short acting. So to restart, etc., it will be very, very easy. Now, so whenever you have a person with heart disease, is it better that you give them a planned delivery, or you would like to for her to get to the spontaneous labor, which is better?
Spontaneous delivery. Most of the patients with heart disease will. Most of the patients with heart disease will undergo spontaneous delivery, ma'am.
Okay, if they don't,
end in preterm labor or spontaneous delivery.
Dr. Josephine, 13 weeks is not delivered. What will you like to do?
Ma'am, I would first preference will be to wait for spontaneous onset of labor. In case patient doesn't go into labor, we can think about inducing labor in all these patients, but provided they should be induced only for the sake of obstetric reasons and not for a cardiac reason. It should be. Before induction, we have to explain to the patient about the pros and cons of induction, risks involved in it, and in concurrence with in liaison, we have to make sure that we inform the team, including the anesthetist, including the cardiologist, neonatologist. Everyone should be informed if we are planning for an induction of labor.
Okay, no, because there are so many advantages in being a planned delivery. In the sense, you can have everybody, you could have it in the daytime, you can plan your delivery. Plus, the importance is you could change over to your heparin. So that will be so that these are the advantages of doing a planned delivery rather than allowing her to get into spontaneous labor. Now, the planned delivery doesn't mean you induce her at 38 weeks. Maybe around 13 weeks you can plan for a vaginal delivery because there the chance of her getting into a normal labor is much more. Okay, you've already spoken about the anticoagulation. Now, what is the protocol? That also I think you've already discussed because you said you would like to change over to heparin. Okay, and then restarting heparin would be anybody?
Vaishnavi?
Yes, ma'am. We'll restart unfractionated heparin around 6 hours after delivery, a normal delivery, and after 12 hours cesarean.
Following a cesarean section within 12 hours, you will, yeah. Okay, no?
Yes, ma'am. And
yeah. Yes, would like to add something? Would you like to add something?
Yes, ma'am. I just wanted to add plan on early mobilization of legs to prevent.
Yes, like you said, that's very important. Yeah. Okay. Huh? And then you have to initially do the bridging, isn't it? So
yes,
the bridging along with it, you restart on your warfarin.
When started on warfarin, an infusion of heparin should be continued and INR monitored. And then gradually we can step up the dosage of warfarin and leave them on warfarin later. And stop heparin.
Yeah,
infusion.
around 3 to 5 days. So you after delivery put on unfractured heparin, and then you will restart your warfarin, and you will on the 3rd day you will see what is the PCINR, and then you will stop your heparin. Okay. Now, like she said, it's very important that you ambulate the patient also. Now, okay, a word about newer anticoagulants.
Directly acting oral anticoagulants are available. They have the same mechanism of action like.
Sorry to interrupt.
I think somebody's on the phone. Can we? Is it Radhika? Radhika, can you mute yourself if you don't mind? Radhika.
Okay. Thank you.
Okay. Yes.
We can use directly acting oral coagulation also, ma'am. But we do have a specification. There is ideally for it comes under the name of rivaroxaban and all those things. We can use it. They are also very much effective, as equally effective as heparin. We can use it, but before in concurrence with the cardiologist, once we discuss, and then we can start.
What about another type of low molecular weight heparin? Because the other thing which is there is quantified. Okay, that also can be used. Okay. Now, do you have time for the? There are two more short cases. Do you have time for it, Madam Sampath Kumar? Madam, do you have time for it? Hello. Can I have the Radhika? Is there time for one case?
Yes, ma'am.
Okay, a short, very quick one. No? This is second case. Severe MS comes with the paroxysmal and orthopnea. She's 6 weeks pregnant. Should she undergo termination or should she undergo a procedure? Yes. Nagasudha.
Yes, madam. It is a multidisciplinary approach. We have to consult with the cardiology team whether she can.
No, she's severe MS with 6 weeks. What would you advise her? One word. Because Radhika is watching.
Termination, ma'am.
We have terminate the pregnancy.
The first time she's got pregnant, what will you do?
If she's
is termination only way? Is there any other option?
We can go for second trimester balloon valvoplasty, madam. PTMC can be tried in second trimester.
You can find out what is the severity and then you can do a BMB if she reaches the second trimester. Okay. Yes.
Second trimester.
Okay. Last question. How will you diagnose PPCM and what is the criteria to diagnose? And what is the latest recommended treatment? Can I have anybody who wants to answer this question? Please.
Patient who is not having a prior cardiac disease, presenting with failure in the last 1 month or 5 months within delivery. She probably it may be having an autoimmune pathology. Echo finding of left ventricular ejection fraction less than 45% and left ventricular fraction less than 35%, madam, 30%. LVED less than 2.7 centimeter per meter square body surface with without any determinable cause. The patient should not have any prior heart disease. This is the criteria to diagnose PPCM. And the treatment modality includes they have to be started on anti-failure measures. They present with failure and bromocriptine can be tried in these cases.
Thromboprofen.
Bromocriptine.
Okay, is there any mnemonic for the latest treatment? Anybody? Nagasudha? Or is there any mnemonic? Vaishnavi Nagasudha? Huh? There's a what is the mnemonic board? Have you heard that?
For peripartum cardiomyopathy, ma'am.
For peripartum, for peripartum cardiomyopathy board. So one is BOARD. B is bromocriptine. Then you have the oral anti-failure measures. Then you have the anticoagulation. And then relaxing agents and diuretics. So that is the treatment for your peripartum cardiomyopathy.
Okay.
Thank you.
So overall, like I said, heart disease increase in pregnancy. It is a very important cause of maternal mortality, and we are seeing a lot of cases of congenital heart disease which are being corrected, and some of them are so complex that you do not know what surgery is being done, what is going to be the outlet. That is what we're going to be faced with, because we see so many patients, babies, having a congenital heart disease, and then they're all correcting. So in the next few years, we're going to, like in Western countries, we will definitely be seeing patients with more and more of congenital heart disease, and age, obesity, and hypertension are also increasing to the maternal mortality. So it's very important that we should not forget a clinical examination and a
proper history taking. That will help us to go along with, because very recently, last month, maybe 2 months ago, I saw a person with 35 weeks of pregnancy. When you just touch her itself, you'll be able to feel the murmur and the heart. She had severe mitral stenosis diagnosed at 35 weeks of pregnancy. So that only means that throughout the 35 weeks, nobody has placed a stent on her. She came with severe disease, and that is how she was referred. That should not happen to us, because, like they said, the first time when the patient contacts us might be the only way in which you can diagnose. There are many things that we as obstetrician would be the first contact with the patient. So many diseases can be made out or diagnosed. So it's very important that clinical examination is very, very important. You must spend a lot of money, especially the first visit, and you might be able to pick up a lot of cases. And I thank all the panelists for the excellent discussion, because I must tell you, none of them knew what questions they were going to be asked. And so thanks to all of them, Dr. Vaishnavi, Josephine, Dr. Vichya.
Thank you so much, ma'am.
For this wonderful discussion.
Thank you.
Fuji and Sampath Kumar and Madam for having given me this opportunity. Thank you so much.
Thank you. Thank you, Chitra ma'am. That was a wonderful panel discussion. And we will remember the mnemonic board for PPCM ma'am. And thank you, Vijaya ma'am and Josephine ma'am and all the panelists. Thank you. And if 1 minute, I'll just check if Sampath ma'am is available.
Radhika ma'am, shall we launch second question?
Okay. Madam Chitra ma'am, there is a question in the chat box, whether they can do sterilization for these heart patients.
Yes, ma'am. Yes, sterilization can be offered to all these patients. But usually we have to counsel the patient regarding the risks and benefits associated with doing female sterilization. Rather than going in for counseling for sterilization for the female patient, we have to counsel for the male partner to undergo vasectomy. Because in cardiac patients, it is if it is going to be a high risk for the female, we have to convince the male partners to go in for vasectomy, ma'am.
Okay, yeah, but if they insist, okay, ma'am. But if they insist, I think the TAT interval sterilization is better.
Better, because they say do the sterilization after 1 month, because there are so many periods of problems which can happen. So they say after a month you can do the sterilization.
And it is a TAT and not the lab, because the lab with
you can either setting an intrauterine device also, ma'am, under strict caution.
Okay.
Yes. Lab will not be advisable, but you can do TAT.
Okay, thank you, ma'am. We'll launch the next question, ma'am. The quiz question, next second quiz question. The contraindications for pregnancy in women with heart disease are all except A, severe aortic stenosis, B, severe pulmonary hypertension, C, prior peripartum cardiomyopathy, D, corrected ASD.
Last 10 seconds.
Corrected ASD.
Time up.
Oh,
10 minutes, we will announce the results.
Okay. Shall we go ahead with the vote of thanks? Vijaya ma'am.
Radhika,
how are you? Nalla irukku. Thank you. How are you? Nalla irukingla ma'am? Okay. So thank you everyone. I thank Revati ma'am, Sampath Kumari ma'am for giving me this opportunity to coordinate this program. I thank Dr. Jaideep Tang sir for taking his valuable time and giving us his blessings and advice. And I thank Dr. Anjalakshmi ma'am, who has given a very valuable talk regarding the heart disease, and she's for being our guest of honor on this day. And I thank the speakers, the two speakers, Bhumika Gunasingh and the other speaker who did very well. And I thank the chairpersons, Vijayalakshmi Madam, for being with us. As in every TNFOG session, she does a great job. And I also thank the panel members. I thank the cardiologist, Paul sir, who came and he gave a wonderful talk on the cardiac registry and the importance of the registering the patients with cardiac disease. And then I also thank Manonmani ma'am, who chaired the session and gave her valuable suggestions. I thank Chitra ma'am for her wonderful panel discussion and enlightened us with all the practical issues with the cardiac pregnancy. And all the panelists, I thank Dr. Vijaya ma'am, who is also my senior PG and guided us in this during my PG, and she and other consultants who participated. I thank Sri Priya and Sahiti for their IT support and coordinating with all the speakers and panelists. Thank you so much for, thank you delegates for being with us. Thank you so much. And we look forward to meet you in the next session. Sahiti, can you please post the...
Yes, ma'am. I'm
Lab
sharing the
for
slide, ma'am.
Okay, we'll post the winners for this session. So for question number 1, which trimester does what happens when the blood pressure during pregnancy in the second trimester? So Janani Priya, Dr. Janani Priya, Tringana Sambandham from Madurai. Congratulations. And for the second question, this corrected ASD is the answer. Dr. Sindhura Maineni from Chennai. Congratulations, Dr. Sindhura. Okay. The prizes will be sent to your address. Thank you, TNFOG team. Okay. See you during the next session. Thank you.